Okay, good day everyone. I am Peter Paul Nobis, your instructor in pharmacology, and today we will be discussing about the drugs that involves in your cardiovascular system. Okay, of course we will be also discussing the cardiac glycosides, anti-anginas, and anti-arrhythmic medications, diuretics, antihypertensive, anticoagulant, antiplatelet, and thrombolytics, and of course your anti-hyperlipidemic and peripheral vasodilators. So of course, no, these are the conduction of your electrical impulses, your sinoatrial node or SA node, which is known as the primary pacemaker of the heart, your atrioventricular node, which is also known as the secondary pacemaker of your heart. No, so SA node, no, usually approximately 60 to 80 beats per minute, in the normal adult, while your AV node has a rate of 40 to 60 beats per minute. So usually guys, no, so if the SA node fails, no, the AV nodes will going to help SA node, no. So siya naman na dahil ma-compensate. That's why your SA node and AV node works hand in hand. That's why it's called your primary and secondary pacemaker of the heart. Cardiac output for the solving for the cardiac output, no. So these are the solving for your cardiac output. So the volume of blood pumped from each ventricle per minute. No? So again, your cardiac output is defined as the volume of blood pound from each ventricle per minute. So the formula for your cardiac output is stroke volume times your heart rate. So and the what do you call this? The unit of measurement for your cardiac output is ml per minute. So your cardiac output has something to do with the preload and then the contractility and of course the afterload as well. So when we say pulmonary circulation, the heart pumps the oxygenated blood from the right ventricle to the pulmonary artery to as lungs. So the pulmonary arteries carries blood that has high concentration of carbon dioxide. Oxygenated blood returns to the left atrium to the pulmonary vein. Nag-aagi siya sa lungs, no? While with systemic circulation naman niya, it's more on peripheral circulation. The heart pumps blood from the left ventricle to the aorta and to the general circulation. Arteries and arterioles carry the blood to capillary beds. Nutrients in the capillary bloods are transferred to cells in exchange for waste products. Blood returns to the heart through venules and veins. Okay, so let's proceed with the cardiac glycosides and anti-anginas and anti-dysrhythmics. So of course, no, for us to fully understood, no, to fully understand if what we'll be using, especially for cardiac glycosides, we will going to define first the heart failure. Heart failure can be divided into two: the left-sided heart failure and the right-sided heart failure. When we say left-sided heart failure, ano difference nila is more on pulmonary manifestation, just like your pulmonary edema, difficulty of breathing, no, or cyanosis, no, pwede din. So that's more on your left-sided heart failure. While your right-sided heart failure naman niya, it's more on peripheral manifestation or systemic manifestation. Jugular vein distension, hepatomegaly, no? And some other no, that involves mga systemic problems that on. But the main cause is heart failure. So that is associated with, again, right-sided heart failure. So what are the non-pharmacologic measures for your heart failure? First, limit salt intake. Alcohol intake should be either decreased to drink one per day. Fluid intake as well. Smoking cessation and avoidance, no? Or stop, no? And then mild exercise such as walking and bicycling. And then your cardiac glycosides, no? It's a group of drugs that inhibits the sodium-potassium pump, resulting in increase in intracellular sodium. Okay? This increase the leads to an influx of calcium causing the cardiac muscle fibers to contract more effectively. Okay, again, ina-influx niya ang calcium, causing the cardiac muscle fibers to contract more efficiently. So your digitalis glycosides, guys, has three effects on the muscles. It could either be positive inotropic effect, negative chorotrophic effect, and negative dromotrophic effect. When we say positive inotropic effect, ginapa-increase siya ang myocardial contraction. When we say negative chronotropic, decrease yan naman ang heart rate. And when we say negative dromotropic naman yan, decreases conduction of heart cells. So these are the three effects of your heart muscle. Positive inotropic effect, pwede siyang myocardial infarction, increase myocardial contraction, pwede siya maka-decrease heart rate, and decrease the conduction of your heart cells. The very common drug that is given as for this one is your digoxin or your lanoxin. It's a rapid acting digitalis, guys, no? Your lanoxin or your digoxin. So it's treatment for heart failure and atrial fibrillation. Again, treatment for heart failure and atrial fibrillation, your digoxin or lanoxin. And then for if the patient is experiencing digoxin toxicity or digoxin toxicity, therefore, there is also an antidote for that, which is called your Digibind. Your Digibind, again, is the antidote for digoxin toxicity or digitalis toxicity. No? Again, Digibind or the digoxin immune pump. Okay? So what is our nursing responsibility? If we are giving cardiac glycosides, again, monitor for pulse rate, no? Especially if magdubo ang pulse rate because the back effect niya is decreases sa heart rate. Okay? Determine as well, no? Signs of peripheral and pulmonary edema, which indicates as your heart failure is present. Then monitor for the digoxin level. No? Usually the therapeutic drug range is 0.8 to 2 mg per ml. A serum digoxin level of greater than 2 mg per ml is indicative of digitalis toxicity. Again, if it's more than 2 mg per ml, no, meaning makakos sa toxicity. Okay? You have to monitor as well the serum potassium level because if it's because again, no, nag-ano siya, nagapa-decrease sa ano, nagapa-decrease sa potassium man sometimes, no? Especially with the taking the cardiac glycosides, nagpa-decrease sa potassium. So if hypokalemia occurs, no, or if present, monitor, you have to refer it to the physician or report immediately to the physician. So these are the other agents used to treat heart failure. The use of your vasodilators because again, para mag-dilate, no, para hindi na mag-overwork si heart nimo. And then ACE inhibitors, no, diuretics, and your reseritide or nactricor. ACE inhibitors, no? Usually, para hapos tandaan sa inyo guys, no? Basta ACE inhibitors yan, guys, nag-end siya sa, ano, nag-end siya sa pril. Okay? Tanan niya ACE inhibitor, nag-end siya sa pril. Okay? Again, sorry, I will just going to write it illegibly. Nag-end siya sa pril. Just like your captopril. Very common is your captopril. Basta ga-end sa pril, ACE inhibitor na siya. When we say ACE inhibitor, it's the angiotensin converting enzyme. No? ACE inhibitor, angiotensin converting enzyme inhibitor. Kaya gina-block ng angiotensin because your angiotensin is a potent vasoconstrictor. That's why gina-block na siya para mag-dilate ang venules and arterioles causing ganaga-pa-decrease ng blood pressure. Okay? And then diuretics as well, that also helps us, especially decreasing the blood pressure. And of course, no, to treat the heart failure. So let's proceed with your anti-anginal drugs. No? So again, it's used to treat for angina pectoris or chest pain. So usually, angina pectoris is a condition of acute cardiac pain caused by inadequate blood flow of myocardium. Pwede siyang due to inadequate blood flow due to plaque formation or blockage. It could either be blood siya o pwede man siya lipids, no? Or decreased blood flow, no? Meaning kung decrease ang blood flow, decrease ang oxygenation, cause sa lactic acid formation or pain. Diba? And then, anginal pain. So, frequently described by the patient as tightness, nagpapalangugot ang iyang dughan, dog sakit ang sa sentro sa iyang dughan, and of course, nag-radiate siya sa left arm. Especially if this, no, if lalo na kung if persist pa siya more than 15 minutes, no? So, it's indicative, no? Pwede siya nga impending myocardial infarction or heart attack. So, again, pharmacologic measure is avoid heavy meals, smoking cessation, strenuous exercises, and of course, emotional absence. Proper nutrition, moderate exercise as well, adequate rest and sleep, and of course, relaxation to prevent chest pain or angina pectoris. The very common drug given for patients with angina pectoris is your nitrates. It's short-acting nitrate, guys, no? So, like your nitroglycerin, pwede siya oral, IV, sublingual, or topical. But the very common one is your topical. Hindi na pa natin na patch, no? So, again, to control anginal pain. And then the other one is your azosorbide mononitrate or Endor. Again, to prevent anginal attack. So, what are your nursing responsibilities, especially in anti-anginal drugs? Again, monitor vital signs, especially nakakos sa hypotension. And then, kung mag-assist kita kay patient, you have to assist the patient, especially in moving out of bed, na dapat slowly siya to standing position because it can cause orthostatic hypotension. And then, have the patient sip some water before giving sublingual nitrates because dryness may inhibit drug absorption. Okay? And then monitor effects of your IV nitroglycerin. Report angina that persists. No? If nag-persist Japon, report to the healthcare provider. And then if you are using nitro patch, do not use with your finger. Use your gloves, guys. No? Do not touch the medication portion because nagapalubo siya blood pressure. And then do not apply sa area kung di kita gabutang sang defibrillator, cardioverter, paddle placement. Because if dila taman ibutang ato niya nitro patch, makakosa burns. Okay? And then these are the other agents used to treat angina pectoris, your beta-adrenergic and your calcium channel blockers. Okay? Okay, so let's proceed with your antidysrhythmic drugs, no? Just like your, when we say antidysrhythmic drugs, it's given to patients niya may cardiac dysrhythmias. It could either be dysrhythmias or arrhythmias. Ano kinalain sa dysrhythmias at arrhythmias? When we say arrhythmia, absence. Again, when we say arrhythmia, absence. When we say dysrhythmia, disturbed heart rhythm. Okay? When we say dysrhythmias, ganun guys, so it could either be too slow ang iyang heart or bradycardic, too fast or tachycardic or irregular gid siya. Okay, again, dysrhythmia, disturbed heart rhythm. Arrhythmia, absence of heart rhythm. Okay? Okay, so these are the classifications of your antidysrhythmic drugs. No? Your class 1, class 2, class 3, and class 4. Again, class 1 is sodium channel blocker. Class 2 is your beta blockers. Class 3 is your drug that prolong repolarization. And then your class 4 is your calcium channel blocker. Anong difference nila sa taapat niyan? So first one is your class 1 is your sodium channel blocker. Again, ginablock niya ang sodium. So may tatlo siya ka-effects. Class 1A, class 1B, and class 1C. So ano kinalain naman sa class 1A, class 1B, and class 1C? So when we say class 1A, prolong ang repolarization. Class 1B, shorten ang repolarization. And then class 1-3 with little to no effect on repolarization. Okay, that's your sodium channel blocker or the class 1 of antidysrhythmic drugs. Class 2 is your beta blockers. No? It reduces the calcium entry, decreases conduction velocity, automaticity, and recovery and time. So again, class 2 is your beta blockers. Class 3, beta blockers that prolong repolarization. And then for the class 4, your calcium channel blockers. So what are these antidysphotic na mga medications. Number one is your specialist or for your class 1 or your sodium channel blocker is your uh, flecainide, no? Flecainide or your Tambocor. Indication for, again, life-threatening ventricular dysrhythmias and prevention of supraventricular tachycardia and atrial fibrillation. Again, is indicated for life-threatening ventricular dysrhythmias and supraventricular tachycardia and atrial fibrillation. And then, your beta blockers. Your beta blockers, di ba, class 1 to is your sodium channel blocker. Your class 2 naman siya, di ba? Your class 2 is your beta blockers, right? Your beta blockers naman niya, so same na Japan. So, it's indicated for ventricular dysrhythmias, atrial, atrial tachycardia, and atrial and ventricular ectopic beats. And then contraindicated with patients with asthma. Okay? So, tandaan nyo guys, no? Basta beta-adrenergic blockers naman yan. Nag-end naman siya, nag-end siya sa katapusan na or sa suffixes niya, nag-end sa olol. Okay, propanolol, no? Metoprolol, olol. So, again, olol, your beta blockers, nag-end sa olol. Para hapos, tandaan guys. Again, para hapos, tandaan, magbatayan yung olol ang punta. Then, beta-adrenergic blocker siya. Or class 2 siya sa antidysphotic ng mga medications. Again, class 1, sodium. Um, and then, class 2 is your beta-adrenergic blockers. Again, class 1, sodium channel blocker. Class 2, beta-adrenergic blockers. And then, your class 3, the drugs that prolong your repolarization is your adenosine. Very common, adenosine. No? Usually given sa patient with supraventricular tachycardia and Wolff-Parkinson-White syndrome. Okay, so please don't be overwhelmed with the cardiac problems because it will be further discussed on your medical surgical nursing on your third year. Okay, and then presence of contraindicated for second or third degree AV block, atrial flutter, and atrial fibrillation as well. The another prolonged repolarization drug is your amiodarone or cordarone. Again, for life-threatening ventricular dysrhythmias. And then the class 4. Your class 4 antidysrhythmic drug is your calcium channel blocker. The very common is your verapamil and deltiazem. No, verapamil and deltiazem. Again, usually for supraventricular tachycardia, tachydysrhythmias, and then supraventricular tachycardia as well, angina pectoris, and hypertension, verapamil. And then, this diltiazem and verapamil guys are indicated both in the second and third degree AV block, and of course, your severe hypotension and severe heart failure. Okay? So, what is our nursing responsibilities with these antidysrhythmias? So, again, monitor vital signs because it causes hypotension. And then, administer drug IV push or IV bolus over a period of 2 to 3 minutes as prescribed. Monitor ECG levels as well, and then report to the physician if there is any abnormalities that will going to occur. Okay, again, just a review. Antidysrhythmic is divided into four classifications. The first one is class 1 or your sodium channel blocker. Class 1 is divided into 3. Class 1A, Class 1B, and Class 1C. And then, your Class 2 is your beta-adrenergic blockers. Again, that ends with inyo nga, ang suffixes ni sa olol, olol, olol. And then your third is your the drugs that involves in prolonged repolarization, just like your verapamil. No? And then the class 4 is your ACE inhibitors or your angiotensin converting enzyme inhibitors, the one that ends with pril, pril, pril. Okay, captopril, the very common ACE inhibitor is your captopril. Okay, okay, so let's proceed with the diuretics. So decrease hypertension. So again, we give diuretics to decrease the hypertension and of course decrease edema in the heart failure. No, again, it can either be peripheral edema or so good. So the very common type of diuretic is your thiazide and thiazide-like diuretic. Okay, so it causes a loss of sodium, potassium, and magnesium, but they promote calcium reabsorption. Okay, it also affects the glucose tolerance, no? Pwede siya nga, increase mo nga blood sugar. Okay, ano yung action sinising mo thiazide? It acts as a distal convoluted renal tubule beyond the loop of Henle. So to promote sodium, chloride, and water excretion. So yun na pa-excrete niya ang excess niya, sodium, chloride, and water. Because again, your sodium, pwede siya gapa-increase maging sa blood pressure. No? If we will go to deal with your renin-angiotensin, aldosterone system. Again, sodium could increase your blood pressure. That's why dapat pinapagawa siya. Okay, so same goes with your potassium and magnesium. Because your potassium is also increase the contractility. No? So if increase the contractility, nag-increase ang blood pressure as well. So the very common thiazide-like diuretic is your hydrochlorothiazide or your HCTZ. Okay, thiazide, or HCTZ to increase urine output, guys, to treat hypertension and edema for heart failure, hepatic cirrhosis, and renal dysfunction. So these are the nursing responsibilities that we should watch out, especially if the patient is taking hydrochlorothiazide. Um, Monitor for the electrolyte levels, especially ba, potassium natin, sodium natin, base hypokalemia kita or hyponatremia kita. And then report for digital toxicity because again, taking digoxin and especially no, if nag-take ikaw digoxin, no, gapa-cause mo sa hypokalemia. Okay? And then again, what is the antidote for your digitalis toxicity? Your Digibind. Again, your Digibind. Digibind. Guys, please take note, mga toxicity nga niya kag at ilang antidote ha. And then observe signs and symptoms of your hypokalemia, just like may leg cramps, weakness, cardiac dysrhythmias. Okay? Monitor for patient's daily weight. No, so if weight din yan is na 2.2 pounds is equivalent to 1 liter of body fluid. Okay? And then note urine output to determine fluid loss or retention. Okay, aside from thiazide diuretic, guys, no, that's mentioned, there is also another type of diuretic, which is your loop diuretic or high ceiling diuretic. No? Other name is your high ceiling diuretic or your potassium wasting diuretics. When we say potassium wasting diuretics, no, ginapagawa yung excess ng potassium because again, it affects the cardiac contractility of the heart. So it can also affect the blood pressure and increase the uric acid levels. No? The very common example of your loop diuretic is your furosemide or Lasix. No? Again, to treat fluid retention, especially for patients with heart failure, renal dysfunction, cirrhosis, hypertension, acute pulmonary edema. So what is our nursing responsibility? Of course, monitor urinary output, notify the healthcare provider if urine so mag less than siya sa expected niya 30 ml per hour or wala siya nag-increase, no? Or wala gid, no? Wala output, severe renal disorder may be present. Then weigh the patient, no, for fluid loss or gain. And then monitor vital signs. And then the another way, no, another type of your diuretic is your osmotic diuretic. No, your osmotic diuretic, guys. No? So it's the only type of diuretic that passes through the blood-brain barrier. That's why it's used to prevent no cerebral edema, especially sa brain naton or intracranial pressure. It also used to decrease intraocular pressure. Okay. The very common example of your osmotic diuretic is your mannitol. Okay, but before you give mannitol, guys, or any type of diuretic, you have to check first the blood pressure because side effect niya guys ang inyong diuretics ka panubo sa blood pressure. So if manubo ang blood pressure ni patient and then you will go into give diuretics, it will further decrease pag ang iyang blood pressure. And then the next one is your carbonic anhydrase inhibitor. Okay? It blocks the action of your enzyme carbonic anhydrase, which is needed to maintain the body acid-base balance. And then inhibition of this enzyme causes increase in sodium, potassium, and bicarbonate excretion. So, ginapa, further excrete niya ang sodium, potassium, and bicarbonate. Okay, because again, your sodium and potassium has something to do with the contractility of your heart. That could affect also the blood pressure. The very common carbonic anhydrase inhibitor is your acetazolamide or Diamox. And then the other type of your diuretic is your potassium sparing diuretic. It's weaker than thiazide and loop diuretics. Weaker siya yan. And of course, no, it is also combined with another drug, no, just like your hydrochlorothiazide and antihypertensive drugs. Okay. The very common potassium sparing diuretic is your spironolactone or aldactone. Okay, again, pwede siya matag for hypertension. So again, it indicates to increase the urine output to treat fluid retention, overload associated with um, heart failure, hepatic cirrhosis, and nephrologic syndrome. So, ang kinalain na niya is, ano, so, hindi siya mo nakapotent compared sa kay loop kag kay osmotic. So, your potassium sparing niya is hindi mo nakapotent. So, what is our nursing responsibility? Note for the half-life of your spironolactone. Monitor for urine output as well, record the vital signs, and of course, signs of hyperkalemia naman. Again, you have to monitor for the signs of your hyperkalemia because again, potassium sparing siya. Okay, so let's proceed with antihypertensives. So again, when we say hypertension, it's defined as increase in blood pressure, such as the systolic pressure is greater than 140 millimeter mercury, and the diastolic pressure is greater than 90 millimeter mercury. The normal blood pressure is less than 120 over 80. When according to American Heart Association, if your blood pressure is 120 over 80 to 139 over 89, it's considered also as your pre-hypertension. And then you're considered as a stage 1 hypertensive client if your blood pressure is 140 over 90 to 159 over 99. And if it's above 160 over 100, you're classified as stage 2 hypertension. Okay, so how to control your hypertension in a non-pharmacologic way? First one is of course no, stress reduction, exercise, no, salt restriction because again nagapataas sa blood pressure ang inyong salt. And then decrease alcohol ingestion and of course smoking cessation. Okay. Okay. So the next one is your sympatholytics or sympathetic depressants ninyo or sympatholytics or sympathetic depressants ninyo, your beta adrenergic blockers. Again, nag-end sa mga ulol, ulol, ulol. Okay? Frequently called as your beta blockers. No? So decrease the oxygen demands of the myocardium by blocking the B1 receptor or beta 1 receptor, resulting in decrease in heart rate, contractility, cardiac output, and blood pressure. So again, this is the very common drug that's given a non-selective beta blockers. There's like your propanolol, and carvedilol. So let's proceed with the cardioselective beta blockers. No? So act mainly on the beta 1. So nag-act lang siya mainly on your beta 1 rather than the beta 2 receptors, and bronchoconstriction is less likely to occur. So less likely to occur bronchoconstriction. Okay, so these are the common cardioselective beta blockers: the acebutolol, atenolol, beta-solol, bisoprolol, and metoprolol. The very common here is your metoprolol and bisoprolol. Actually, these are the two common cardioselective beta blockers given to the patient. And then for nursing responsibility, of course, monitor vital signs and of course laboratory tests, especially for the kidney, um, liver test, and liver function test and some other tests as well that I will be able that will help to support the results of the laboratory. Okay, so let's proceed with the centrally acting alpha 2 agonist. So when we say centrally acting alpha 2 agonist, no, so it decreases the sympathetic response from the brainstem to peripheral vessels. It stimulates the alpha 2 receptor, which in turn decreases the sympathetic activity. So increased vagus activity, decreased cardiac output, and decreased serum epinephrine, norepinephrine, and renin decrease are released. The very common centrally acting alpha 2 agonist is your methyl dopa, clonidine, just like your clonidine as well, and guanfacine. Sorry, guanfacine. Okay, so let's proceed with the alpha adrenergic blockers. No, so when we say alpha adrenergic blockers, it blocks the alpha adrenergic receptors, no, resulting in vasodilation and decreases the blood pressure. Again, kinablock na to ng ang adrenergic receptor. Therefore, it results into vasodilation and decrease the blood pressure. Okay, and same for patients with diabetes as well, because do not affect glucose metabolism, do not affect respiratory function. The very common is your prazosin, terazosin, and doxazosine. Okay, what have you noticed on your alpha adrenergic blockers? Nag-end siya sa zosin, zosin, zosin. Okay, take note guys ha. This is another technique para ma-memorize niyo. Ay, okay. Zosin ang ending niya. So, meaning, alpha adrenergic blockers na sila guys. Okay? Useful also in treating hypertension in patients with lipid abnormalities, no? Especially if ang ila hypertension related sa cholesterol levels. If taas ang cholesterol level niya daan, taas ang blood pressure man. Because again, there's a presence of nagkakakuan siya sa iyong mga blood flow. No? So there's something na pwede siya nga ma-impede, no? Because there is already a plaque formation for that due to lipids. So your nursing responsibility, of course, to monitor vital signs and of course check daily for fluid retention in extremities and weight gain. Especially prazosin may cause sodium and water retention as well. So again, it causes sodium and water retention. Monitor also for the electrolyte imbalances. And then the next one is your adrenergic neuron blocker or peripherally acting sympatholytics. Just like your uh, ano naman ni ang kwan ang action sa imong adrenergic neuron blockers. No, so gina-block niya ang norepinephrine. Your norepinephrine guys, tandaan ninyo ano ang function sa norepinephrine. Kapataas ni sa guys, no? Kapataas sa sang BP, your norepinephrine. Since ginablock ta ang norepinephrine, no, sa imo nga sympathetic nerve endings, guys. Ah, ginapa ay ginablock ta sa gani, guys, ang ato niya norepinephrine. So kay tungod niya ginablock siya, anong result niya? Ma-decrease ang BP. Okay? That will, ang bala, guys, yeah, that will, norepinephrine release, causing the decrease in norepinephrine release, that results in lowering the blood pressure. So hindi na amo na kadami yung norepinephrine na gina-release, so lower down ang blood pressure. And then alpha-1 and beta-1 adrenergic blockers, no? So duwa na siya, alpha-1 and beta-1 adrenergic blockers, no? So it blocks alpha-1 and beta-1 receptors, no? Because by blocking the alpha-1 receptor, guys, cause of vasodilation. Okay? And while by blocking the cardiac beta-2 receptor, guys, it could block the heart rate. Both heart rate and atrioventricular contractility are decreased, no? Again, so beta-1 and alpha-1 adrenergic blockers cause of vasodilation, and then ma-decrease ang heart rate and atrioventricular contractility. And then the next one is your direct acting arteriolar vasodilators, no? So it relaxes the smooth muscle of the blood vessels, mainly on the arteries, no, causing vasodilation. The very common drug is hydralazine and minoxidil. And then, as mentioned kagaina, angiotensin converting enzymes, no, inhibitors, no. So your ACE inhibitor, no, it blocks the angiotensin 2, which is a potent vasoconstrictor. So kaya ginablock ta ang vasoconstrictor, therefore naga decrease in mga blood pressure. Kaya di ba ang di ba ginablock ta ang angiotensin 2 kaya nagka-cause ang vasoconstrictor. So kung ginablock na siya, ma-dilate ang vessels or makakosa o makapromote sa vasodilation. Okay? And always remember, guys, no, your angiotensin converting enzyme nag-end siya sa pril naman niya. Okay? Pril, mga pril. Benazepril, captopril, enalapril, lisinopril, pisonipril, no? But the very common here is your captopril. Very common din siya, guys, nga ACE inhibitor. So what are your nursing responsibilities? Of course, check for the blood pressure, especially sudden drop of your BP. Monitor laboratory tests, no? Just like your BUN, CREA, and protein, no? Especially for the kidney function. And then check for hypoglycemic reaction in patients with diabetes mellitus. And of course, report for healthcare provider, or just like my bruising, petechiae, and bleeding, no? Because it indicates severe adverse reaction to an angiotensin antagonist, such as your captopril. Okay, so let's proceed with your angiotensin 2 receptor blocker, or it inhibits the release of your aldosterone, where aldosterone is your sodium retaining hormone. Okay, so kay tungod na gina-inhibit niya ang release of aldosterone, so gina-inhibit niya man nga mag-retain ang sodium nga nagakos ang pagtaas ng blood pressure. Okay, so it may cause the vasodilation as well, and it decreases the peripheral resistance. The very common angiotensin 2 receptor blocker is your losartan, Cosar. Okay? Losartan, valsartan, irbesartan. So, tanan niya nag-end sa tan gani, guys. Again, tanan niya nag-end sa tan is your angiotensin 2 receptor blocker. Okay? And then direct renin inhibitor. It binds with renin, causing the reduction of angiotensin 1, angiotensin 2, and aldosterone levels. No? So the very common is your aliskiren. No? So it can be used alone or with the use of other antihypertensive agents. And then your calcium channel blockers. No? Very common calcium channel blocker is your verapamil. Okay? It's also called as your calcium antagonist and calcium blockers because, diba, as we said a while ago, it's something to do with the contractility of the heart, right? Your calcium. That's why you try to block because the more nga ga-contract, the more nga ga-increase ang blood pressure. That's why, Ina-block ang calcium. And then at the same time, you try to block the calcium channel in the vascular smooth muscle cells because it promotes vasodilation as well. Okay, so let's proceed with the anticoagulant, antiplatelet, and thrombolytics. When we say anticoagulant, it inhibits the clot formation. Usually, it is used for patients with venous and arterial disorders that put them at risk for clot formation. The very common anticoagulant is your heparin. Okay? Always remember, guys, that if we are having a heparin therapy, we have to monitor for the PTT and the APTT. Okay? It indicates for rapid anticoagulation effect when thrombosis occurs. Prevents coagulation by combining So, kumbaga, the main function of your heparin is it prevents coagulation. On the word itself, anticoagulant, meaning it prevents coagulation. Of course, no, dapat kung heparin therapy, again, monitor ang partial thromboplastin time and activated partial thromboplastin time. Because again, uh, the patient has a bleeding tendency. Okay, so heparin can also be a low molecular weight heparin. So when we say low molecular weight heparin, no? So same man Japan, like your heparin. But, paano siya galing, no? Low molecular weight fraction lang siya galing sa standard yung heparin natin. So thereby, it causes a lower risk of your bleeding. No? Again, it causes the low risk of your bleeding. Just like your Rivaroxaban Xarelto is an example of your low molecular weight heparin. No? Usually ginatag na siya to as prophylaxis for deep vein thrombosis. Your Rivaroxaban Xarelto. Xarelto is the brand name. Rivaroxaban is the generic name. Then, if masubrahan gani guys, tandaan nyo guys, no? If masubrahan gani guys, so aside from the anticoagulant nga heparin, gahatag man kita warfarin. But if magka-warfarin overdose gani guys, no? Usually, the antidote for your warfarin is your vitamin K. Okay? Warfarin, vitamin K yung antidote. Kung warfarin toxicity. For heparin toxicity na naman niya, it's your protamine sulfate. Again, vitamin K is an antidote for your warfarin toxicity. Your heparin is protamine sulfate. Usually, if we try to monitor the warfarin or comadin, we use the PTINR. And for the heparin therapy, it's APT. Okay? We have to monitor the platelet count as well, no? And then examines patient mouth, no? Especially if they're bleeding ang gums, nose for epistaxis, urine for hematuria. So there's a presence of blood, guys, no? And that's why fecal occult blood test as well is obtained, no? To check, if there is a presence of blood, no, that would indicate a bleeding, no, internal bleeding. So antiplatelet drugs, no? So used to prevent thrombosis, no? From the word itself, antiplatelet drugs, it used to prevent thrombosis, no? So it can either be to prevent myocardial infarction or stroke as well, no? Or to prevent the repeat, no, recurrence of stroke or MI, or to prevent for patients having transient ischemic attack. Hindi siya magtamaan. Usually the very common here is your clopidogrel. Clopidogrel is the generic name. Plavix is the brand name. So this is the very common antiplatelet drug. The next one is your thrombolytics. No? Thrombolytics is promotes a fibrinolytic mechanism. The very common thrombolytic drug is your alteplase, TPA or tissue plasminogen activator, or urokinase. Again, pwede siya urokinase or alteplase. You have to monitor the vital signs for the nursing responsibility. Again, monitor vital signs, observe signs and symptoms of bleeding, examine patients for active bleeding for 24 hours, observe for signs of allergy as well, and then avoid administering aspirin with or NSAIDs for pain and discomfort. Or the safest that we can give is acetaminophen to be substituted. And then monitor electrocardiogram for presence of perfusion or dysrhythmias. Because again, if we are using antiplatelet medication, no, or anticoagulant, no, dysrhythmias will also appear, no. So that's why the antidysrhythmic therapy man kung indicated yun. And then avoid venipuncture or arterial sticks because again, very prone to bleeding. Okay, so we're down with the last one, anti-hyperlipidemic and peripheral vasodilator. So lipoproteins, no? Just like when we say lipoproteins, mga lipids ninyo like cholesterol, triglyceride, and phospholipids. Hyperlipidemia or hyperlipoproteinemia refers to a condition with an excess of one or more lipids in the blood. So when we say, actually there are major categories of your lipoprotein. Your high density lipoprotein and low density lipoprotein. High density, meaning dapat it should be maintained high because it's a good cholesterol or a friendly cholesterol. While your low density lipoprotein is a bad cholesterol. That's why it should be maintained low because it's bad. So if there's an elevation of your low density lipoprotein, meaning there is an increase in your bad cholesterol in the body. Okay? These are the major categories of lipoprotein, low density and very low density lipoprotein and chylomicrons. No? Carries most triglyceride and less cholesterol for very low density lipoprotein and for chylomicrons naman niya are large particles that transport fatty acids and cholesterol to the liver. Of course, no, what are the non-pharmacologic measures that we can have for reduction of cholesterol intake? No? Again, reduce saturated fat and cholesterol intake. Read the label, especially for giving or buying appropriate foods. Choose lean meat, no, especially chicken and fish, no. And then exercise is very important, and of course, smoking cessation. So let's go with the anti-lipidemics, no, drugs that lower lipid levels. So such as the bile acid sequestrants, fibrates, nicotinic acid, cholesterol absorption inhibitor, and hepatic 3 hydroxy 3 methyl glutaryl coenzyme. And then what is our nursing responsibility? Of course, monitor the lipid levels, monitor the laboratory test, no, especially the liver function test, and then observe for the signs and symptoms of GI upset. Because again, with the use of your anti-lipidemic drugs, no, um, this could also cause GI discomfort. And then peripheral arterial vascular disease or peripheral arterial vascular um, or disorder. Okay? Usually a common problem in older adults in peripheral arterial disease. No? So usually characterized by numbness and coolness of the extremities, intermittent claudication. So meaning, when we say intermittent claudication, pain and weakness of the limb when walking, but no symptoms are at rest. And of course, possible leg ulcer. Your personal nursing responsibility is you have to monitor the vital signs, especially the blood pressure and the heart. Now, tachycardia and orthostatic hypotension can be problematic with peripheral vasodilators. And of course, aside from that, you have to assist the patient, especially in performing activities of daily living. Okay? And of course, observe for pressure ulcers as well, because again, very prone sila sa pressure ulcer. So that's all for my discussion about the drugs that involves in your circulatory system. And thank you so much for listening, guys, and have a great day. Goodbye.